Welcome to the deep dive. This is the show where we really try to give you that expert shortcut to foundational knowledge.
Especially for high-stakes material.
Exactly. And today we've got a custom dive that is, I think, perfectly tailored for you, the medical learner. We're looking at a concise but really thorough overview of a bedrock text.
Netter's Obstetrics and Gynecology, second edition.
That's the one. A critical source.
It really is. I mean, it's authored by Dr. Roger P. Smith, a clinician, and it leans so heavily on those, world-famous Netter illustrations to make complex ideas clear.
And the scope we're covering is huge.
It is. We're going from the absolute basics like the hormonal start of puberty all the way through lifelong screening, and then into some really complex clinical management stuff.
Like pregnancy loss and infertility.
Exactly.
So our mission today isn't just to, read you the chapters. It's to synthesize the most critical physiological concepts, those essential screening protocols, and the practical clinical pearls.
Those details that really make a difference in practice.
That's what we're after. Maximum knowledge density, but through engaging analysis. Okay, so let's unpack this. I think we should start right at the beginning.
The timeline of female physiological development.
Yes. Let's trace that out.
It's the perfect place to start. To really get a handle on obgyn, you have to understand that normal sequence of sexual maturation.
It's foundational.
It's absolutely pivotal, not just for counseling young women, but for spotting when something is going wrong. For identifying abnormal progression that might need intervention.
So what kicks this whole process off physiologically? We always hear hormones, but what's the actual, the cascade?
It's all about a fundamental reset in the endocrine system.
The reset.
Yeah, exactly. See, puberty involves this big shift away from a state of intense negative gonadal feedback.
Where the body is super sensitive to even tiny amounts of estrogen, right? It's keeping everything suppressed.
Precisely. And it shifts to establishing these really complex circadian and ultradian gonadal rhythms. These are the frequent cycles that eventually drive the whole monthly system.
So the hypothalamus basically just becomes less sensitive to that estrogen break.
That's exactly it. The hormonal cascade really begins when the hypothalamus matures and its sensitivity to estrogen goes way down.
And that frees up GnRH production.
Yes. That decrease allows for the release of gonadotropin-releasing hormone, GnRH.
And once GnRH is flowing, the pituitary just follows its lead.
You've got it.
Yeah.
As a result, follicle-stimulating hormone, or FSH, levels start to rise, usually around age 8 to 10. That leads to a rise in estrogen.
And then it just keeps going from there.
It's a feedback loop. As that hypothalamic sensitivity keeps dropping, both FSH and luteinizing hormone, LH, climb and climb until they finally hit a threshold.
A threshold high enough for ovulation.
High enough for cyclic ovulation and finally menstruation.
That whole transition from suppression to cycling is it's profound. What I found really fascinating in this source were the three non-hormonal elements.
Ah, yes.
The external factors required for this to happen normally.
They get overlooked all the time in favor of the hormones, but the source is so clear on this. For puberty to progress normally, you need three things: adequate body mass, adequate sleep, and exposure to light.
It just highlights how systemic it all is. Environmental factors are co-drivers here.
They absolutely are. If you're seeing abnormal timing in a patient, you have to investigate all three of those things.
Okay, that's actually a perfect transition point. We've talked about the physiology of development.
Right, at the very beginning.
So now let's move into, the lifelong work of maintenance, of preventive care. Let's talk about routine screening for an adult patient.
Okay.
What are the key periodic checks the source material really emphasizes?
For adults, two tests really stand out as standard. First, the Pap test. But the clinical pearl here is that the frequency of follow-ups is up to the physician and patient.
After a certain point.
Right, after 3 consecutive normal results, assuming the patient is low risk. The second big one is cholesterol and HDL levels, which should be checked every 5 years.
And then beyond that, it's really risk-based, isn't it?
Completely. STD testing, HIV, mammography, fasting glucose. That's all based on individual history and risk factors.
But that whole strategy shifts pretty profoundly when a patient enters that 40 to 64-year-old age bracket.
Oh, absolutely. That phase is all about 2 major transitions: the natural shift towards menopause and the emergence of common age-related health changes.
So the monitoring has to get tighter.
Much tighter.
How do those protocols change specifically?
Well, Pap tests generally continue,
Yeah.
but you add some critical new checks. Colonoscopy and a lipid profile are added, again, depending on the risk
Or
factors.
mammograms.
The guidance there shifts. It's every 1 to 2 years until age 50, and then it moves to yearly screening starting at age 50.
Let's talk about bone density because the recommendation here is very specific, which I think is a great example of evidence-based screening.
It is. A bone density assessment is not a universal recommendation for all postmenopausal women younger than 65. The source really stresses that it should only be done if the results are actually going to influence a treatment decision.
So practically speaking, you're only screening women who already have risk factors for osteoporosis.
Exactly. It's for when early detection would actually change how you manage their care. You're screening for intervention, not just for information.
That clarity is so important. Okay, moving into clinical application. Let's tackle contraception. This is where it gets really interesting because the source acknowledges that, the perfect efficacy of a method.
It often takes a back seat to real life.
Right. To lifestyle and adherence.
It's true. The selection really comes down to 4 key factors: accessibility, immediate availability, cost, and, crucially, the method's impact on spontaneity.
So a method with perfect efficacy is useless if the patient won't use it consistently.
Or if it just negatively impacts their life or is too hard to get. Absolutely.
Let's apply that to a few specific patient groups. What about new mothers who are breastfeeding? What are the constraints?
Okay, for breastfeeding mothers, barrier methods are always fine. The real concern is usually about hormonal methods and milk supply.
Right.
So the source confirms that oral contraceptives are okay if milk flow is already well established. And here's a practical pearl. Long-acting progesterone contraceptives might actually slightly increase milk production.
That's interesting. What about IUDs?
For IUDs, placement has to wait. The uterus needs to return to its normal, non-peripheral size, basically until it's fully involuted after delivery.
And shifting to the other end of that spectrum, what about patients over 35? This is such a high-risk group when it comes to oral contraceptives or OCs.
It's a really important clinical area. Patients over 35 can safely continue using low-dose OCs, but there is one non-negotiable condition.
Let me guess. Smoking.
They must not smoke.
Right.
And they must have no other significant vascular risk factors. That's the rule.
The source did note a positive trend there, though.
It did. Compliance tends to be better in this older group, which makes use-oriented methods more reliable. But, and this is critical, they have to understand that contraception needs to continue until menopause is clinically confirmed.
So what are the appropriate long-term alternatives for this age group? The ones that get around those hormonal and vascular risks?
The source lists long-term methods like intrauterine devices, IUDs, long-acting progesterone, or sterilization as all being appropriate options for this group. They're highly effective and they mitigate those risks.
Timing is so essential in prevention, but also in a crisis. The source points out how fast the body can recover after a pregnancy loss.
It's remarkable. Ovulation can return in as little as 2 weeks.
Which means if a patient chooses OCs after a loss, they have to start them immediately.
That rapid return to fertility is such a critical counseling point. And it brings us to a really crucial topic. Classifying and managing abortion, meaning pregnancy loss, correct diagnosis, and timely diagnosis, is everything for maternal safety.
And diagnosis rests on a few key signs.
Vaginal bleeding, cramping, passage of tissue, and the status of the cervix, specifically the Oz.
Okay, so if a patient presents with bleeding and cramping, but no tissue has passed and the cervix is closed, that's a threatened abortion.
Correct. And for those cases, if there's no cervical change, you really want to keep intervention minimal. Reassurance, encouraging normal activities. You only really intervene if there's hemodynamic instability from pain or bleeding.
But what is the one key diagnostic finding that just changes the whole game?
It's seeing tissue visible at the cervical os, along with cervical dilation.
That specific combination.
That specific finding is diagnostic of either an incomplete or an inevitable abortion. It means the pregnancy can't be salvaged, and your focus shifts entirely to maternal safety.
So what are the management protocols in those two situations? They sound serious.
They are. For incomplete or inevitable abortions, surgical evacuation, usually curettage, is generally required.
Why is that?
Because the risks of severe hemorrhage and infection are just too high, even if some tissue has already passed spontaneously. For a missed abortion, where fetal demise occurred, but everything remains, evacuation is done with either D&E or medical therapies like prostaglandins, depending on the stage.
I want to focus on the most severe scenario here. Septic abortion. The tone in the source material implies, life or death urgency.
It absolutely does. Septic abortion is a massive threat to the mother's life. It requires immediate aggressive management. No delays.
What does that management look like?
It means broad-spectrum parenteral antibiotics immediately, aggressive fluid therapy to maintain stability, and critically prompt uterine evacuation.
That evacuation is mandatory.
It's mandatory, and it's often done while the patient is still being stabilized. The mortality associated with delaying intervention is just too high.
Wow. Okay. That need for immediate evacuation really underscores the clinical weight of that diagnosis. Let's shift gears a bit into applied diagnostics, the workup for infertility. When you're facing a couple struggling to conceive, what are the 3 core goals of that evaluation?
The strategy is very systematic. It focuses on identifying the 3 critical elements you need for conception. You have to confirm, 1, that sperm is available and functional.
Makes sense.
2, that an egg is available and being released, so is ovulation happening. And 3, that the sperm and egg have the time and the place to actually meet.
Which means you're checking for things like tubal patency.
Exactly. Tubal patency and a healthy uterine environment. The whole diagnostic process just systematically investigates those 3 areas.
And for those cases that do end up moving to assisted reproductive technology, the source gave some stats on IVF success rates. They're from 2004, but still insightful.
Yes, and it's important to remember that rates are highly variable and always improving. But that 2004 data showed IVF techniques accounted for about 5% of infertility services, and they had roughly a 32% live delivery rate per egg retrieval.
Let's dig into a specific diagnostic tool that's often used in that workup. Sonohysterography, or SIS. How does that help visualize the uterine environment?
SIS is a brilliant, minimally invasive technique. It basically uses warm, sterile saline as a contrast medium.
So the fluid helps you see things.
Right. It distends the uterine cavity so you can get a clear view with the transvaginal ultrasound. Its utility overlaps with more invasive things like hysteroscopy or biopsy, but it really excels at documenting subtle anatomical issues inside the cavity.
And what specific pathologies is it best at documenting?
It is particularly good at clearly documenting endometrial polyps, submucously myomata.
So fibroids that bulge into the cavity.
Exactly those. And also intrauterine adhesions. Because the saline pushes the walls apart, these structures that are normally kind of hidden become clearly outlined against the fluid. It's a simple procedure, just a catheter, 5 to 30 milliliters of saline, and you watch in real time.
Okay, finally, let's close with a really practical clinical procedure. Pessary management for pelvic organ prolapse. The source mentions all these different types, ring, cube, Gellhorn, but it says regardless of the device, there's one crucial follow-up detail.
Yes, this is a true clinical pearl.
Why is that immediate follow-up so important?
The most critical detail is that an examination 5 to 7 days after the initial fitting is absolutely required. You cannot skip this.
And why is that?
The reason is simple, and it's serious. This follow-up ensures proper placement. It verifies the patient can maintain hygiene, and most importantly, it confirms there are no pressure-related problems.
Like vaginal trauma or even necrosis.
Exactly. So if the pessary is too large or it's misplaced, that necrosis can happen incredibly fast.
Wow.
The pressure can lead to severe tissue damage and ulceration very quickly. That's why that initial check is just non-negotiable for safety and for long-term effectiveness.
This has been an incredibly high-density synthesis. I mean, connecting those delicate hormonal shifts of development all the way to the rigorous requirements of clinical safety.
We've covered a lot. The shift in preventive care needs across a lifespan, the strategy behind contraceptive choice, and the necessity of immediate correct action for acute obstetric events. The bottom line for a medical learner is that critical thinking is everything. Knowledge is only valuable when you can apply it correctly in a time-sensitive situation.
So what does this all mean? As a final high-yield review for you, our learner, let's test your integration of these clinical pearls with a challenge question.
Let's do it.
Based on the source material, why might low-dose oral contraceptives be contraindicated for a patient older than 35 who smokes? And what 2 alternative long-term contraceptive categories are listed as appropriate for this age group?
Okay, great question. The absolute contraindication for combined OCs in a patient over 35 who smokes is the massive increase in vascular risk. We're talking thrombosis, stroke. The guideline is crystal clear. They must not smoke and have no other risk factors.
And the two long-term alternatives that were cited for women over 35.
Those were long-term methods like intrauterine devices or IUDs and long-acting progesterone contraception.
That is the perfect distillation of the safety and the strategy you need in that clinical scenario.
Excellent integration of the knowledge from Netters.
Exactly what we were looking for. Thank you for joining us on this deep dive into foundational obgyn material. We hope this comprehensive analysis gives you the edge you need.